So thank you, everyone. So we're about to kick off the second panel, which is the follow-up to abnormal non-colonoscopy testing, moving from policy to implementation. So have shuts up. So I'm Frank Colangelo. I'm an internist at Premier Medical Associates, which is in suburban Pittsburgh, Pennsylvania. I practice primary care and lead quality efforts for our practice. Premier is also part of the Allegheny Health Network, which covers the whole Western Pennsylvania footprint. And I've been involved with efforts to follow up abnormal testing for some time. I mean, Rich Wender is going to get sick of hearing this, but there was a day about 10 years ago when I realized that only 57% of our patients with a positive FIT in the year before had had a follow-up colonoscopy, and I called him frantically, and he said, "Relax, you're doing better than most of the country is." So, but he also gave me a series of things that we put into place that over time allowed us to increase our follow-up rates above 80%, so we reached Kaiser-type range there. But that was affected, thank you. That was affected during the pandemic also. I mean, that we changed nothing, but that follow-up rate over 18 months dropped to 55%. Now we've been able to recover back into the 80s since that time, but we're going to hear some presentations today about, what's been going on in this recently. And I have three speakers with me today, and I'll introduce the three of them right now. So Molly McDonnell is going first. She joined Fight Colorectal Cancer in October of 2019 as their Director of Advocacy. In that role, she oversees Fight CRC state and federal policy and advocacy efforts. She'd worked with multiple clients across the healthcare sector to creatively tackle their most pressing policy and advocacy challenges. And she's going to share with us the latest policy landscape, which includes some very impressive victories over the last year to help with completing the CRC screening paradigm. Second will be David Lieberman. Dr. Lieberman's a professor of medicine, was the chief of the Division of Gastroenterology and Hepatology at Oregon Health and Science University. He's an internationally recognized expert on colon cancer screening and has served as a leader of numerous national organizations and has authored numerous peer-reviewed articles on the subject. He will share with us updates on closing the screening continuum. And lastly, I've worked closely for many years with our next speaker, Dr. Elizabeth Ciemins, who is a health services research scientist and vice president of research and analytics at AMGA, the American Medical Group Association. In her role, she focuses on data-driven population health improvement through comparative and predictive clinical analytics. And she will share with us work that has been done over the last year on developing a HEDIS measure for timely colonoscopy completion following an abnormal stool-based screening test. So Molly's going to go first and share with us, the policy updates. Thank you, Molly.
Hi, everyone. I'm Molly McDonnell, and I am the Director of Advocacy for Fight Colorectal Cancer. We're a national patient advocacy organization dedicated to the colorectal cancer community. And it is my distinct honor today to talk about some of the policy victories that we've had over the past year or so around the colorectal cancer screening space. And I just want to start by saying that while I'm lucky enough to get up here and be able to talk about the victories that we've had in the past year, this work has been a decade or more in the making, and many, many people in this room have contributed to it. So it just is a testament to what we can do when we all work together. So for those of you who aren't familiar, Fight Colorectal Cancer is a national patient advocacy organization dedicated to the colorectal cancer community. We provide patient support and educational materials. We focus on policy change, which is the work that I do, and we also support research. So I want to start by just talking briefly about our Catalyst state-by-state advocacy program. So the work around the follow-up colonoscopy policy really was both a state and federal effort. So in 2019, Fight CRC launched our Catalyst program, where we provided financial and technical support to grantees at the state level that were working to advance policy to increase access to colorectal cancer screening. So when the program launched, our focus was really around two policy areas. One, ensuring coverage for screening beginning at age 45, which at the time was just in ACS guidelines, but obviously, as we've talked about today, is now many additional guideline bodies have agreed. And then, of course, removing cost sharing for colonoscopy following a positive non-invasive test. And so we really wanted to be able to leverage the relationships that we had built at the state level to build on the great work that has been done by other organizations that were operating at the state level, like ACS Can, Prevent Cancer, and others, and to really make sure that colorectal cancer was made a priority. And so I just want to briefly shout out our Catalyst Advisory Council, again, ACS Can, Prevent Cancer, and CDC, and many of the strategic partners and sponsors that help make this work possible. And so to start by going through a little bit of the state landscape around follow-up colonoscopy. So as you can see here, the light blue states are where legislation around follow-up colonoscopy has passed. And the darker blue is where there's still legislation pending, and the stars identify where there are catalyst states. So as you can see, it's a diverse range of states. This didn't just happen in blue political states, but we saw states like Texas, Arkansas, Indiana also take the step to change this policy, and really showing that it's a nonpartisan, common sense issue. And I think seeing the work that happened at the state level really helped catalyze, if you will, the work that we were able to do at the federal level. So this is just kind of a high-level timeline around the follow-up colonoscopy policy efforts. So I did want to also mention something that Steve mentioned earlier in his remarks, back in 2012 when the Medicare loophole bill was first introduced. So again, this was policy that would ensure that Medicare patients that went in for a screening colonoscopy and had polyps removed would not wake up with an out-of-pocket cost. So in that work, we also were talking about the follow-up colonoscopy, but it took many years to be able to move that forward. So then over the next 10 years or so, like I said, we had a number of states that were able to advance follow-up legislation and sort of show that this was good policy. It wouldn't break the bank. These states didn't collapse, but instead they were able to move forward. Then in December of 2020, again, as Steve mentioned, the Medicare loophole bill was signed into law. So that was an incredible victory, and obviously, a decade in the making. With that policy, the cost sharing for Medicare beneficiaries will be phased out over a period of time. Essentially, that's a bit of a gimmick that they do on Capitol Hill to sort of push out the cost of the legislation so that it sits outside the budget window. So our hope had obviously been to have that cost go away immediately, but we're still happy to see it move forward and that we're moving in the right direction. So then over the next couple of years in particular, as again, I mentioned, there's a lot of different organizations and folks that have worked on this issue, but in particular, we were able to partner with ACS Can and the American Gastroenterological Association to reach out to both CMS, but also a group of federal agencies that promulgate regulations for commercial plans. So we had sent a series of letters and had a number of meetings, in particular with these tri-agencies, so the Department of Health and Human Services, the Department of Labor, and the Department of Treasury, around the importance of the follow-up colonoscopy and ensuring that folks who are undergoing these non-invasive tests and get a positive result are able to complete screening. And so in January of 2022, those tri-agencies issued an FAQ where they detailed that, in fact, commercial insurers do need to cover that follow-up colonoscopy without cost sharing to the patient. We also had a series of meetings with CMS on the same topic. And again, those are meetings that had been going on for a number of years. Each year, they would kind of nod and say, yes, we agree, we think this is important, and that would sort of be the end of the meeting. But this year, we were really excited that in July of 2022, in the physician fee schedule proposed rule, they also proposed to make this change around the follow-up colonoscopy. And then in November, in perfect time for this meeting, which I would love to take credit for, but CMS really did me a solid on that one. They finalized their proposed rule, and so as of January 2023, Medicare beneficiaries will not see an out-of-pocket cost for that follow-up colonoscopy. So just kind of a very, very high-level overview of kind of what that coverage landscape looks like. So between the FAQ for commercial plans and the Medicare guidance, that obviously covers ACA-compliant plans, and Medicare, it also covers the Medicaid expansion population. But in terms of traditional Medicaid, there's a question mark there because we just don't really have a great sense of exactly what that landscape looks like. I would say anecdotally, we know that for most Medicaid beneficiaries or many Medicaid beneficiaries, they typically don't face out-of-pocket costs. But that's definitely an area that we've talked about in the policy task force, shout out, about needing to get a better sense of exactly what our Medicaid patients are facing in this and other areas of colorectal cancer screening. What the recent victories do not address is grandfathered or other non-ACA compliant plans, which we were also talking about in the policy task force yesterday, is a greater number of plans than you would imagine. So that's definitely a place for further activity. And then, of course, the uninsured, which is a big area that we at Fight CRC intend to focus more on, but I think certainly as a community and as a roundtable is important that we remain focused on. So a couple of different, now that we've had these great victories, obviously we need to celebrate, and that's really important because these victories don't always happen that often, so the celebration is important, but we also need to think about implementation. So a story that I mentioned yesterday, or not a story, but so 10 years ago, those same tri-agencies came out with guidance to commercial plans around the polyp removal issue. And again, said that if a patient goes in for a screening colonoscopy and polyps are removed, there should be no cost sharing for the patient. That was 10 years ago. We're still hearing from patients who are waking up with an out-of-pocket cost. So implementation is a key part of this effort. It's one thing to have the law pass, it's one thing for the regulation to become finalized, but to make sure that it's actually being implemented and patients are actually seeing the value of that is incredibly important. And so something that Fight CRC is thinking about with many of our partners is, how do we start to do that work? And how do we, one, think about the different audiences that we need to address? So patients, physicians, health insurers, coders, billing departments, electronic medical record companies. There's a lot of different players, obviously, in this space, and that can impact the way that patients are navigating this journey. So on the screen is an example of something that one of our Catalyst grantees in Louisiana did, developing a flyer for physicians in their state, and they mailed it to over 3,000 physicians, kind of explaining the change around the follow-up colonoscopy policy and what they can expect as physicians and what they can expect for their patients. So I think thinking about what that messaging looks like for each of these different audiences, and also how we meet these audiences where they are, is a really important piece, and would love to continue to have that discussion with this group. Also, the state work does continue in this space. So we are supporting grantees in New Jersey and Virginia that are continuing to work on advancing legislation to remove cost sharing. So really making sure that it's codified for their state. And these two states in particular are ensuring that it is addressing their traditional Medicaid population in their states. And I think in particular, as we see the judicial challenges to the Affordable Care Act and to the preventive services benefit, it's going to be all the more important to continue to make sure that these benefits and policies are codified everywhere that they can be. And we are continuing to look to work in additional states. So one thing I'll mention here is that for the Catalyst program, we've obviously had these two policy priorities that we've been working on, but we also want to hear from states about what is important to them, what ideas they have. So a great example of that was mentioned earlier was the work that's being done in Kentucky. So we were fortunate to work with Dr. Jones and Jason around the pharmacy protocol in Kentucky, and working to, again, meet patients where they are and explore this innovative idea of a way to get more folks into screening. So if your state is interested in this work, definitely find me after this and be happy to chat and talk about ways that we can work together. The other thing I wanted to touch on, again, earlier I mentioned the uninsured population. We've been thinking a lot about how to build on the existing successes we've had in this space. So in particular, the CDC's Colorectal Cancer Control Program. It's a program that's obviously done great work with the uninsured and underinsured population, but is currently only operating in 35 states. So we've been working for a number of years and are continuing into the future on how we can work to increase funding for the CDC's Colorectal Cancer Control Program, but also look at other existing models and see what we can replicate to make the program even stronger. So for example, the breast and cervical program, which is different in many ways, but a particular element is that for patients that are diagnosed through the breast and cervical program, if they are uninsured, they will be eligible for Medicaid for their treatment. So that's something really important for us to think about as we continue to screen people. We'll obviously diagnose more people. And so to make sure that we are thinking through that full journey and not just leaving people hanging when they have this horrible diagnosis, but we're making sure that they're able to be navigated to treatment as well. So that's something that we're looking forward to working on over the year ahead. And I will just, since I have a couple of minutes, for that work, just plug, in March, we have our annual advocacy event, Call on Congress, March 13th and 14th. So this is an event where we bring advocates from all across the country to Washington, D.C. We provide advocacy training to help get them ready to have an effective and successful meeting with their members of Congress. And it's a really amazing experience to bring patients, survivors, and caregivers, loved ones together. And I think it's also really important to have representation from many of the folks in this room, to have public health professionals, physicians, researchers, social workers. I think it really helps tell the story in a much stronger way, and just to show patients that we really are all in this together. So I would definitely encourage you all to attend. And again, thank you everyone in this room for all of the work that you've done to help contribute to these great victories, and I'm just glad that we can all be here together to celebrate it.
Thank you, Molly. So next, Dr. Lieberman is going to discuss closing the screening continuum, updates from the American Gastroenterological Association.
Great, thank you very much. It's really a privilege to be back at this meeting and to see so many people here. And I'm sure everybody's happy to be back face to face. I'm going to talk a little bit about some activities that the American Gastroenterological Association, that's a tongue twister, is working on. And as you know, this is an organization that's pretty passionate about colon cancer screening. So in 2021, the AGA launched a screening initiative task force, which I was honored to have the chance to chair. And the goal initially was to define the continuum of care so that when patients go in and get screening, that the entire continuum of screening, which would be follow-up of positive non-invasive tests, follow-up of detection of polyps, things that you just heard about from Molly, are included in that continuum. We published a policy statement in June, and in this process, we identified several areas that we felt were very important. First, to the importance of identifying high-risk patients. And I think there's still some confusion in the primary care community about who is average risk and can have any form of screening test, and who is high risk and needs to have more intensive screening with colonoscopy and perhaps more frequent examinations. So I think trying to identify that group, establishing the follow-up of non-invasive tests, and the follow-up of patients after they've had neoplasia detected. So what do I mean by the continuum? I think that it's been pretty well defined. We know that if somebody has a non-invasive test and that test is positive, that they have an increased risk of colon cancer and advanced polyps in their colon and should get a colonoscopy. So the continuum should include that colonoscopy. If somebody has primary screening colonoscopy, goes to colonoscopy, has a polyp detected as shown here, that polyp should be removed. We shouldn't just look at it, and it should be removed, and that should be part of the continuum. The continuum, there have been barriers, of course, financial barriers to screening that Molly just talked about, and I think I'm not going to spend much time on this slide, except to make the point that closing these barriers has just been so important, and it's a big win for our patients. So I'm really pleased with the efforts of Fight CRC and the many organizations that worked to try to close some of these important loopholes. So I want to spend most of my time really talking about where I think we need to go next. And we know that screening can be effective. We know that it works if it's done. And I think one of the highlights of the recent study that many of you saw in the New England Journal of Medicine called the Nordic study, in which patients had screening colonoscopy, is that colonoscopy is only, screening with colonoscopy or any other modality is only going to be effective if it's done. And one of the limitations of that study is that only 42% of the patients invited to have a colonoscopy actually got it done. So the results were not as exciting as people expected, although it clearly is a study that demonstrates that colonoscopy works, that it can reduce incidence, and if you get it done, it can reduce mortality. So how can we improve adherence? And this is from the paper that we published, that Dr. Lieberman and I published in June. And this is from some modeling that he did. So highlighted in red, you can see that with the current colon cancer screening uptake, based on the surveys that we've heard about in this meeting, that we can expect, and with a breakdown of about 55 of that percentage coming from colonoscopy and 10% from FIT, which is roughly where it is in the United States today, we'd expect to see colon cancer prevention in about 47% and mortality reduction of about 53%. So we asked ourselves, well, what if we could actually achieve some of the goals that the NCCRT has set out? So we set a more lofty goal of 85%, and suggested that if this increase occurred, that it might be, if it was predominantly non-invasive testing, that we could still achieve a very significant increase of going from 47 to 60% in incidence reduction and from 53 to 68% in mortality reduction. So I think this tells us where we can go and provides a bit of a roadmap for what is possible. And that's why I call it vision, hopes, and dreams. And I know that everybody in this room is really dedicated to achieving this. So what are the challenges? And I think this group knows better than anybody what some of those challenges are. It's education and awareness. We've been talking about the importance of reaching people at their place, in their homes, and at a younger age, so that they're tuned into the concerns about colon cancer at a much younger age. So awareness is going to be important. Access is important. And we just talked about, well, what if people are uninsured, or what if they are not getting adequate access to primary care? So access is going to be important. Adherence to screening when it's offered. So if it's offered but it's not done, it's not going to be effective. Disparities. We know that there are some significant disparities in the United States. And amongst the barriers include socioeconomic issues, access to health care, transportation. If a colonoscopy is needed for some individuals, the transportation becomes a major barrier. Time away from work. So if you have a kind of job where your boss isn't going to let you off to go ahead and have a colonoscopy, that's a barrier. If you're taking care of a child, or you're taking care of, you're doing elder care, that's going to be a barrier. And so these are amongst the disparities. And one that I didn't list here, but I think is important, knowing that 41 states are represented here today. Rural communities, I think, have some barriers as well, because access to getting colonoscopy in some parts of the country is actually very difficult. So how do we try to overcome some of those barriers? Well, I think one way to look at it is to look at some successful models. And I've only picked two. There are several others that I could have selected. But I want to highlight two of them because some of their representatives are here at this meeting today. So one is the Kaiser experience, and T.R. Levin is here. And they achieved an greater than 80% adherence with a subsequent reduction in colon cancer incidence, mortality, and elimination of disparities. So that's a model I think that we ought to be looking at as within an organized healthcare system. This is possible. We can get over 80%, and we can see the impact of that within a decade of the time that that program was initiated. The C5 program in New York has reached out to very diverse communities in which colonoscopy has been offered, and it's extremely successful. And there are many people here at this meeting that have been involved in that program. So I asked myself, as I look at these successful programs, what's the secret sauce? What made these programs work? And I think the answer is pretty simple. It's first, creating access. So in each one of these programs, access to the screening program was created for everybody. Okay? There was no discrimination based on insurance or non-insurance. So that was one issue. The second was effective communication that reached people where they were. And so that required some thinking, but I think it's been demonstrated to work. And then third is providing navigation. This is something that Keith Winfrey highlighted this morning in his presentation. Navigation becomes a pretty important part of how this program is going to work, and we really need to think about it programmatically. So what do I mean by navigation? And Keith may want to make some comments as well about what he was talking about. But for me, navigation is several things. It's providing education and answering questions that arise so that when people have questions, they know where to go to try to get some answers. Providing access to the test. Reminders to complete the test because we know, all of us know, that we're not so good at doing it the first time necessarily, but we may need a reminder. And I think one of the things we learned from the Kaiser program is that reminders do work. And then, what if the test is positive? Well, we know that individuals with a positive non-invasive test will have an increased risk of colon cancer, 2 to 4-fold higher risk of colon cancer compared to those with a negative test. They need a colonoscopy, and for some, getting to that colonoscopy can be an issue and a problem. And for all the reasons that I mentioned, such as transportation, time off work, childcare. So working to try to help patients overcome some of those barriers, I think, is all part of navigation. So I just want to highlight the study from T.R. Levin again, because I think it really provides us an important lesson. So when they initiated their program around 2004 or so, TR, I believe that, and it was predominantly, they were starting to mail FIT kits to everybody on their birthday. And if the FIT kits were not returned, then they got a reminder. And you can see what happened to the screening rates. It wasn't all FIT that they ended up with. They ended up with patients getting colonoscopy screening and getting other forms of screening. But within that 10-year period, you see that the overall screening rate in their group of individuals over age 50 at that point had reached 82%. So pretty extraordinary. And again, it shows what's possible in an organized program. This is what happened to mortality. So in a relatively short period of time, we're seeing a pretty significant reduction in mortality from colorectal cancer. And I think this paper that was just published this year from Chaik Dubeni, working with TR and the Kaiser folks, demonstrated something else that's really important, an important lesson. And that is they looked at the incidence of late-stage colorectal cancers. And at the beginning of the program, you can see that there was a significant disparity between black and white men and women. And by the end of that program, that disparity had been eliminated. And I think the lesson there is that when we provide access and navigation, some of these disparities that we've seen in this country, can be fully eliminated. So that's, I think, a really exciting finding out of this study. So how do we do all this? And I think, it's got to be, in my opinion, kind of a multi-pronged approach. Access is obviously the beginning and is essential. And then navigation, as I said, I think is an extremely important part of this. But I think dealing with some of these other barriers, such as the coverage of the screening continuum so that there is no cost sharing, has been shown to be effective as well. And then addressing some of these issues about disparity, rural locations, et cetera, that might be important. So we've, at the AGA, in our AGA group, have kind of outlined an approach, and that I just want to let you think about, and it involves many different potential stakeholders. So obviously, our first goal was to define the continuum and what elements we felt were important. But I think the next step is going to be to partner with a lot of the people that are in this room. So that includes industry, so companies that are producing non-invasive tests, either now or tests that will be available in the future. Endoscopy companies have a stake in this because these patients, some of them will end up getting a colonoscopy. Payers have a stake in this because if they're interested in preventive health, this is one way to improve health. But also, and I think this may be compelling for some payers, is the opportunity for health equity. That if that study by Dr. Dubeni is confirmed in other settings, we can eliminate a lot of the healthcare disparities that we see in the United States. Patient and provider groups like FIGHT-CRC and others, I think, are important partners as well. And then, as was alluded to by Molly, I think there are some interesting experiments that we could consider doing. Healthcare has been traditionally provided by primary care providers and healthcare organizations, but I think if we begin to think more broadly about retail health, there's a lot more that can be done in the Walmarts, Amazons, Walgreens, CVS's of the world. And I think engaging with them to see what might be possible. And I think the experiment in Kentucky, is potentially, one opportunity to do that. It's going to be important that high-risk individuals be be identified, though, if we do this, so that they are referred for the appropriate screening that they need. But I think that could be another stakeholder. I think potential other stakeholders could include the transportation apps. I mentioned that transportation, I have patients that tell me they cannot get a ride to a colonoscopy. And I don't know if you all have experienced that in your practices, and it becomes a tremendous barrier for them. And so we bend over backwards in each individual case to try to provide transportation. But what if the Ubers and Lyfts of the world were partners in this effort and wanted to help improve healthcare in the United States? So I think those would be possibilities. And obviously, patients. The endoscopy side of this, I think, obviously we want to be able to provide high-quality colonoscopy care for those patients that need to get colonoscopy. And that's where I think the GI organizations can be somewhat helpful. So I guess my last slide here is that it takes a village, and the village is right here. It's right here in this room. And we have 41 states represented. We have many organizations, healthcare providers that are here. And I think we know that education plus access plus navigation can improve adherence. So thank you very much.
Thank you, David. Now Elizabeth is going to talk about developing a measure.
Hello, everyone. So I'm going to talk about developing a CRC follow-up screening measure. I'm from AMGA. We are a not-for-profit trade association, and our members are healthcare organizations. So multi-specialty medical groups, integrated delivery systems, academic medical centers, and now more recently, some federally qualified health centers. Because we are no longer dominated by medical groups, we just go by our acronym AMGA, kind of like that other health-conscious organization, KFC. So one of the things I was asked to do is to explain what is the process of measure development. And my outline kind of lays out the process. So first, we specify the measure based on the literature and based on our data. We do some exploration in data to see how it looks. We do reliability testing, feasibility testing, and then phase validity. I'm going to go through each of those steps. AMGA, I told you a little bit, but what we do advocacy. So we're helping our member organizations move from volume to value. We do quality improvement, mostly around chronic disease management, but also prevention, like immunizations and cancer screenings. And then we do research. I have to step over here, I can't quite see the slides. And that's where I sit. So I'm in the, I lead our research department, and really what we're focused on is trying to get evidence-based practice into routine healthcare, so helping our members do that. We do that through innovation, whether it's technological innovation, but really mostly innovation in ways of delivering care. And then we really heavily rely on data, so we try to understand hidden meanings in the data, figure out what's driving change, et cetera. So we have members in all 50 states. We have over 400 member organizations, 175,000 more than that physicians, and we end up serving, who end up serving 1 in 3 Americans. So pretty broad reach. And we also have data on a subset of those members, which were the yellow circles. These are some of our members, so pretty diverse. Many organizations you recognize, some you may not. We have small, medium, large groups, et cetera. So I'm going to talk mostly focus on this measure development project. It was funded by AARP, who's interested in developing measures for older adults. Now I know we're getting younger with this group, but they sponsored this, and we worked together with Optum Labs for the data. So we didn't do this alone. We had a group of advisors who are all here or were here. Mary Barton was here yesterday, so they've helped guide this process. So our objective was to develop and test a colorectal cancer screening follow-up measure, measuring timely follow-up with colonoscopy after a positive stool-based test. So we sort of start with the current HEDIS measure, which, you know, we like to call the half-assed measure, because it doesn't quite go all the way, right? It only measures screening, but not the follow-up. I figured you'd all heard that before. So we start there and start with some of those criteria. And then we develop the measure, we specify the measure. So this is what it looks like visually. So we are looking at a eligibility year for patients who who have a positive result from their stool-based test, and then look for follow-up in 6 months. And this is so based on the HEDIS measure as well as the evidence that in 6 months is when you start seeing risk of cancer. And then so you have to follow up for that extra 6 months, of course, the sooner the better, but this was the time frame. So this sort of repeats that. For this study, or the database look, we actually shouldn't say 2018 guidelines, but we looked at the older guidelines because we looked at the years 2016 through 2020, so this is focused on 50 to 75. So the data for the study came from Optum Labs Data Warehouse. It's a de-identified claims clinical database. So we focused on the EHR data, and that includes outbound claims and from 38 healthcare organizations. When you just look at EHR data, as you know, you may miss some treatment like colonoscopies if they were performed outside the contributing health system. So we did a sub-analysis, and we found that we were missing about 8.6% of colonoscopies that were done outside and were not recorded in the home system. So some of this is slightly under performance. So we excluded for this analysis by age, the same as the HEDIS measure, history of malignant CRC diagnosis, total colectomy, hospice care. And then in our data, we were not able to distinguish clearly between screening and diagnostic, so we added a few more criteria, which was excluding a hospitalization or ER visit within 14 days of a positive test, and we looked at that and found that those were mostly diagnostic, as well as the actual CPT codes for diagnostic tests. So this is an attrition table, sort of where we started and where we ended just for this analysis. I won't go through the whole thing, but we started with about 200,000 patients over the 4 years. That was cut by about a half once we applied all those exclusions, and we ended up with 20,000 patients in 2018 that we used for this analysis. So these are the patient characteristics. I'll just point out that It's not necessarily a representative sample of the United States. It's of the data that we have, which is mostly white, non-Hispanic, commercial. More than half have commercial insurance, and more than half have zero comorbidities. So take that as you will. So then we look at measure performance. So how did the measure perform? So we're looking at the percentage of patients who had that positive stool-based test who received a colonoscopy within 180 days. So these are the 38 healthcare organizations that we looked at. So the median rate is 48%, less than 50%. On the top is the size of the system, so a big range, and that's how many patients that they had. So ranged from, I think, 39 to 5,000. But what you can see on the bottom there is that there wasn't a correlation, like the bigger size systems weren't doing any better than the small. It was pretty wide variation. And this is what we always find when we look at our data across our systems. So the range was 13 to 67%. So even the highest was only 67%. So looking over time, overall, you can see that it has increased since 2016, but then a drop during COVID. I just wanted to mention we did a separate analysis looking at the impact of COVID even beyond. And so we heard a lot of good news that during COVID, just screening was staying the same because people were doing stool-based tests. However, the follow-up dropped when we looked in a separate analysis by about 10 percentage points after COVID. And we looked at the month of the index. So people who came in March of 2020 never caught up a year later. The others caught up to the average for 2020, but nobody caught up to 2019 rates. So to me, there's still people out there that, we should be reaching out to, especially if this happened during COVID. So this is the performance over time by the healthcare organization. So just to show you that there's a lot of diversity there. And then we look at it by some subcategories. So measures now are often being required to be reported by race or ethnicity or other factors. So this is probably not surprising that whites had the highest rates and the others fell below, and these were statistically significant differences. Ethnicity, kind of the same story. Age, we do see higher rates, in that lower age group, which is a little different than for the initial screening. But these results were not statistically significant, so these were basically no differences. So then when we evaluate the measure, we did a sensitivity analysis and then reliability testing and feasibility testing and face validity. So the sensitivity analysis we did is we wanted to look at, well, what if we looked at 90 days instead of 180 days? So is there a big difference? So on the bottom are those 38 systems. The purple bar is looking at the measure within 6 months versus 3 months. And the mean is 36% if we look at 3 months versus 44% for 6 months. On the top is the difference. So there wasn't a relationship between higher performance and less of a difference, which we might think, between the 90-day and the 180-day. And you can see the minimum and maximums are pretty wide range once again, even as low as 8% for 90-day follow-up. The reliability testing, so we want to make sure that the test is reliable, meaning that we look at a signal-to-noise analysis. So we want to make sure we're looking at a signal, true differences between whether you're looking at health systems or providers versus the error. So a good reliability that we're looking for, if you look there at the bottom, for an individual is 90%. For groups, which is how we looked at it, mostly because there weren't enough, individual providers didn't have enough patients to look at it by provider. So we're looking for 70 to 80% for groups. So here's our reliability results, highly reliable, all over 90%. If you look what's in blue, that's the mean reliability for healthcare organizations. And the way you interpret that is that 90% of the variance in the measure was due to between system differences instead of error. So it's one of the tests you do for a measure, which is good. Feasibility testing, so then we had 3 health systems conduct a feasibility assessment. So we asked health systems about the data elements that would be included in the measure. Is the data available? Is it accurate? Is it coded using a nationally accepted standard? And is it collected during routine course of care? So these are the data elements that we asked for, and we actually updated it and added being able to distinguish between a screening and diagnostic test, because that will be important. This is one of the results from one of the health systems. So their issues, one was with being able to identify hospice or palliative care within 12 months. And I'll just go to the next slide to show you why. So for hospice or palliative care, it was just that they were not able to capture that 90% of the time. So that got a 0 rating. The other two were something that we imposed so that we could distinguish between the diagnostic and the screening. Because this was a medical group, they didn't have access to the data from the hospital. So they weren't able to identify inpatient visits and ER visits. However, they also weren't getting that data, so it didn't really matter. If you're getting the data from a hospital and it's mixed into your data, then you'd want to be able to identify that if we want that to be part of the criteria for a measure. So face validity is another piece of this. So what we did is shared our results. This separate analysis was supported by Exact Sciences, where we did some qualitative interviews. So the one thing we do is share the measure specifications with providers in health systems, see if it makes sense to them. And we also conducted face validity with our advisors. And then some qualitative insights. I don't have time to go through all of them, but this one you've heard people say this, that there was this lack of knowledge about failure to follow up. So I think every single provider we interviewed, when we asked them, how many of your patients do you think are following up if they have a positive stool-based test? They all said, all of them. Like, why wouldn't they follow up? And so they were shocked, just like Frank said he was shocked, to find out that the rates were less than 50%. And a lot of the reason is they don't get these data, so they don't know, and they're just making these assumptions. So, that was one of the quotes. So I have some other qualitative themes I don't have time to go through, so I'm going to just summarize the facilitators and barriers, and a lot of these we've heard yesterday and today. But some of the facilitators are having an integrated EHR, transparent reporting. So if we, what the group said, if we had the data, that would really help, and we could see how we're doing, how easy it is to refer, having dedicated staff, and that anticipatory guidance, which people have talked about, when you give a stool-based test, there's that you have to get a colonoscopy if it's positive. And then the barriers, some groups don't have gastroenterology, so there's that breakdown. Some of the communication of results, we heard some stories about patients getting a result saying, your physician is going to contact you about your result, and then the physician didn't get it and never contacted the patient. And so that just needs to be tightened up, and that actually, some of the physicians said, I'll never do stool-based tests again because they weren't confident they were going to get the results. So I think there's been improvements, but that was brought up. And then also not having a typical process, something that's just built in, baked in process for follow-up of these patients who had a positive test. And of course, they all thought that if they could actually see the data, that would be really helpful. So in summary, the CRC follow-up measure, it met the criteria for a quality performance measure if submitted by health systems. So there's variation in the performance. It was reliable. It was feasible. We might need to simplify that exclusion criteria about inpatient ED visits, but that was perhaps just something with the data that we had access to, we weren't able to distinguish, and it passed the face validity test. So the next step, so we had, Mary Barton from NCQA was on our advisory panel, and the next step is that they will take all the work that we've done. They'll determine if additional testing needs to be done, although she's letting us know so we can get it all done now. And then it will go through a process of being posted publicly, which, so you're going to ask me when, right? So I talked to her yesterday about this, and she said it probably couldn't actually be, they would be doing this work in 2023, then it would be posted publicly January of 2024, and probably wouldn't be an official measure until 2025. But that was the time frame she gave me. So thank you.